Yes, my name is Terence. I'm the Senior Technology Advisor in NHSX, and we're going to be talking about open standards and their roles for urgent and emergency care. So, what are open standards? Well, we have a very long technical explanation which we have just lifted wholesale, more or less, from GDS, Government Digital Service. And what we're basically saying is that when computers talk to each other, they need to do so in a common language. That language must be well-defined, must be mature, it must be freely available, and it must be compatible with open source. And you can read a full definition on that website. I think these slides are being made available afterwards. But why do we need them? I mean, it is the cliche that doctors have horrific handwriting, and there is a prize for anyone who can decode this particular prescription. See me afterwards. But we also have this. It's a nasty problem. We are being told that data is the new oil, and it's absolutely true. Data is messy, it's expensive, and if it leaks, it causes irreparable harm. We want to make sure that the data that we're gathering, that the data that our systems send between each other, is open, it's clean, it's really easily accessible, and it is not going to cause confusion, pain, or any harm. We also want to make sure that you heard earlier from Simon that we need to get value for money. We want to be able to buy systems from around the world. We want our systems to talk to systems from around the world, and we can't do that if we have an NHS-specific language or a single company-specific language that these systems speak. The good thing is, we already use open standards throughout the NHS. I mean, here's just a few of the ones that we use. When NHS websites are designed, they use HTML5, a nice open standard. We do not release, I hope we don't release any NHS websites which say best viewed on Internet Explorer 6. That would be disastrous. We say, if you're doing text encoding, use Unicode. We want to make sure that all the APIs that we create are documented in the Open API specification so that you do not need to register to download a PDF to try and read to understand how this system speaks to that other system. Can't be doing with that anymore. We've got to get faster, we've got to get better, and we've got to get more open. And there's a whole bunch of medical standards as well, which we'll go into in a bit. If you only take one thing away from our talk, I want it to be this, and I've made this as simple as I can. We will not approve digital spend unless it complies with open standards. Take a photo of that, tweet it, print it on a t-shirt, send it to your CEOs, your developers, your designers. If you come along and say, we've got this brilliant system, and it will trap all of your data in our proprietary language, we're going to go, no, sorry, we're not buying that. We cannot afford to have our systems locked away. We cannot afford data to be locked away in single vendor proprietary solutions. That is not the way we are working anymore. If the solution that we are being presented does not comply with open standards, we are not going to spend money on it. No ifs, no buts. And there are some really strong reasons for this. We want to be able to understand what is going on throughout the NHS, because just stick your hand up if you've changed GP since you were born. I think that's at least 90% of people. We kind of have this mental model sometimes in the NHS that is your GP, and your GP will stay there, you will stay with that person for life, and your data will just be over there. And the reality is we live complex, multifaceted lives. We move around. We move houses, we do all sorts of silly things like getting married and going off and having adventures and coming back and going to foreign countries. And we want to make sure that the data can flow as easily as our lives. So here's an interesting example, I think, which is on ICD-10. There are some really weird codes in here, like shock due to being struck by lightning. Maybe that's not so weird. But there's one which, when I saw, it was injured due to a fridge. Who gets injured due to a fridge? Well, anyone who remembers those old Charlie Says info films from the 70s and 80s know that we used to have a real problem with kids getting injured in fridges. But if that data isn't being recorded in the same way across the country, how do we know that our efforts to stop children getting injured in fridges is working? How do we know if there is an epidemic of something unless every single emergency care provider is recording it in a consistent way? And again, we don't want doctors to have to, and clinicians to have to remember all 100,000 of these codes. As Sophie said, these need to be user-focused systems that we're designing, but at the back end, they need to use open standards so that we can understand the big picture of what's going on. I'm going to take a worked example for you. This is going to be slightly interactive, and I make no apologies for that. Does anyone know what date this is? What day of the week this was? What date it is? It's ambiguous, isn't it? Just stick your hand up if you're from North America or somewhere else which does their dates wrong. Differently. This is ambiguous. If we have people writing dates down like this, or systems recording dates down like this, it becomes a problem. Stick your hand up if you had the misfortune to learn Latin at school. Okay, what date is this? That's up on there. Again, I have a prize. 1888. Lots of people learn Latin, so no prizes. We probably want slightly more modern solutions than this. So at the back end, what we're saying is, if your system is recording a date and timestamp, it should use the snappily named ISO 8601, which looks like this, which goes from biggest to smallest and has a time zone. Time zones are really important because, as we all know, come daylight saving times, people go, did this person receive an injection at 3 a.m. or was that 4 clocks went back or went forward? Which way? We need to make sure that the systems in the back end can record data clearly and absolutely unambiguously. And that's a sort of metadata issue here. Much to my mother's disappointment, I am not a doctor, so I don't know whether 107 watts over 60 watts. I have no idea. Is this a healthy thing? Well, which part of the body was this measurement taken on? Is this actually blood pressure resistant? We need to make sure the systems that we use open standards to record the full set of data, which can be clearly and unambiguously understood by other systems. And to explain a bit more about that, I'm going to pass on to my colleague, Matt.
Thank you. I'm Matt Stibbs. I'm a product lead in NHS Digital. I've spent most of my career working in urgent emergency care, and I'm acutely aware, as will many of you be, that urgent emergency care is not one big single monolithic service. It is actually a massive web of services trying to provide a joined up experience for the patient. And for a very long time, we had to do that without services being able to talk to each other. It's not a health specific problem, this happens all over the place. We have emergency services to tell each other about serious incidents that are going on. The police are not able to tell the ambulance services that there's a major incident, the fire service can't tell the Coast Guard about information that they have. It has to be done manually. This was tackled a few years ago, a collaboration between emergency services and the government to develop a standard called the multi-agency incident transfer standard, MATE. And that standard is now part of the standard specification for emergency service systems. People are building those systems so they can talk directly. We've had a standard for talking to ambulance services in urgent emergency care for 5 years now, and initially that was designed to allow a 111 service to tell the ambulance service that the patient needed help. But actually now we're seeing people build on top of that standard. We're seeing ambulance services talk to other ambulance services, and more recently we're even seeing our English ambulance services starting to work cross-border with Scotland, Wales, Northern Ireland to be able to transfer information about patients cross-border as well. When 111 was first rolled out 5 years ago, our interoperability landscape was pretty simple. We had a pretty simple flow, 111 into an out-of-hours GP service. But we did establish a standard at that time to support that. The reality of urgent emergency care now is much more like this, and this is not an accurate service map, referencing Sophie's thing. These are just some lines that are meant to look complicated, but actually the reality is we have people flowing all over the place in the system, and we've introduced 111 Online, which we'll hear about later. 111 Online actually integrates with our urgent emergency care services, but that was only really made possible, viable, cheap enough and simple enough because we already had a standard established that allowed 111 Online to talk to the services. And the reality is our commissioning models are changing really quickly, and they should be if we're going to carry on adapting the system. And only by having standards established can we allow ourselves to adapt quickly without having to redo everything that we've got in place technologically. A lot of these building blocks remain the same. So open standards allow us to try new things. If we specify some of these building blocks as open standards, we can start to build platforms on which people can build cool, useful new tools. And we heard Simon talk about the importance of bringing SMEs in to innovate and to help us solve some of our biggest problems. But we do have to do the groundwork in order to make that possible. If we make these open standards well documented and published, available on the internet, people can have a look at what we're offering, they can look at the building blocks that they can use, and they can start to think about novel ideas. I was really pleased recently that we had a couple of examples of people building on top of our Directory of Services APIs. The Northeast have a capacity management tool called UC Radar. And they've integrated service information from the Directory of Services into that tool, so they're taking a real-time feed from the directory. That wasn't something that we centrally specified, that was just something that they decided to do because they had the building blocks there. Likewise, we've had an ambulance service recently integrate the Directory of Services into their mobile terminals that crews are using on scene, allowing them to get information directly in real time about services that are available for patients. The thing is though, it's no good us just developing our own standards, as Terence has said. We need to make use of familiar web standards that are already out there. For two reasons. One, why would we do it ourselves? Secondly, because if we want to attract the interest of internet era companies and modern SMEs, people who are working in technology, and especially people who are not already working in healthcare, we need to use things that are familiar to them. An example of that would be, there is an open API specification for publishing API details. We should use it. People are familiar with it, it just lowers the friction, and there's an expectation that the friction is lowered. Open standards also help people to contribute, and this is really important because up until the last few years, I think standards have been within the domain of technologists mainly, and we know that this actually isn't good enough. And we've seen lots of movement around collaboration and wider contribution to standards. But if we publish these standards openly, we can get more people involved. We need more than technologists, we need clinical experts, we need operational experts, we need users, and we need subject matter experts from the industry. By working in the open, we can allow these people to contribute at their own pace and in their own way. By way of example, we've been doing some work with appointment booking in urgent emergency care, and we publish all of our work openly. People can see the state of our thinking at any point in that journey, and they can challenge it or contribute. Open standards also help us to make better procurement decisions, and we know that people struggle with knowing what to buy, knowing what the right standards are to buy systems in line with, and we know that suppliers struggle to know what to build into their systems. So we should be publishing these standards openly so that we have a benchmark set between people procuring and people supplying. We're talking the same language and not trying to feed these things down through complex commissioning chains. Terence?
So, as I've mentioned before, we need this. This is non-negotiable. We need to be able to analyse the entirety of the NHS to understand exactly what's going on. We need to make sure that open standards mean there is no room for ambiguity. We simply can't afford it, both in terms monetarily and in terms of the health of the nation, which is why NHSX will mandate open standards. We are going to work with you, with users, to work out where we don't know what standards to use. We will work with the community, understand user needs, get those user stories, work out the mappings, and say, look, this is the standard that will be used for this part of NHS technology. And we will mandate that that's what's going to happen. No, again, no ifs, no buts. This is the most powerful tool that we have as technologists to improve the NHS. We want to make sure that the smallest company can compete with the largest. We want to make sure that we're never again in the situation where someone signs up to a 10-year contract and all the data is held in a proprietary language and we can never get it out again, and we have to pay massively to extract the data that we own. I'm being told that we only have 2 more minutes, so I'm just going to leave this slide up for 2 more minutes. I want you to absorb it into your brains. I want it tattooed on the inside of your eyelids. When someone asks you, hey, how was the conference today? I want you to just reply to them, NHSX will not approve digital spend unless it complies with open standards. Thank you very much indeed. Cheers.
Do we have time for questions? We have time for 1 or 2 questions. Okay. We've got a question at the front of the room here. Do we have a mic?
Mike speaking out.
Crack on, yep.
Can you wait for the mic for the live stream? Cheers. Just a sec.
I totally agree with everything you said, but how do we ensure that standards keep up? I was on a call yesterday with Debbie, with the Pathways team, looking at where a standard's been used very successfully for 4 or 5 years. In fact, the same standard we described there, but it's now being used in situations it was never intended. It doesn't do the job it was meant to do. Yep. So how do we make sure these standards keep up with all the evolving?
There's 2 things. One is looking at user needs and making sure that the standard is being applied correctly to the user needs. The second is we should be choosing living standards. We're not going to say, we're going to choose the 1998 specification and then never move from there. We're going to be looking at standards which evolve, and where possible, people from the NHS should be involved in the continued development of those standards. So we don't want to develop our own standards, but if, to take a pocket example, HTML5, we have people throughout government who work on the HTML5 specification and can feed back into that. If there is a user need, we should be helping drive those standards forwards to meet our user needs. So we don't want to end up with old fossilized standards, but a very good question.
Any other questions? There was another hand up before. No? Okay. Thank you very much indeed. It's brilliant. Cheers. We're now actually going to go to